and to promote critical thinking. This morning I want to ask you first off to take your cell phone out like I'm going to do right now and turn it off to make it silent anyway. So the program will be recorded and actually going to be videotaped, this presentation. So it'll be available, but you can listen to KKFI in about 10 days. I think it's on Wednesday 10 days from now. This morning we're really pleased to have with us a panel of expert medical professionals, including Beth Andes, a longtime member of this church who organized this event. Olo, and I can't pronounce it, Szylleyko, he is a neighbor of mine, and so is David Terry is also a neighbor of mine. So my neighborhood's well represented here. But anyway, the topic today is Medicare for all, and I have opinions, but I'm not going to share them till later. So, Beth?
Thank you so much for coming out this morning, and I'm really excited to do this presentation. I'm from Raytown, so I'm not one of the neighbors. They live in a ritzy neighborhood, just FYI. So the way this morning's going to go is I'm going to give a slideshow presentation, and then we're going to open it up to questions, at which time David Terry, who's practiced OBGYN and psychiatry, and Olo Szylleyko, who's a clinical pharmacologist and works in the clinical pharmacy industry, will be with me helping to answer questions, and we really are looking forward to a vigorous back and forth today. So I do want to expand on the title of my talk, because what it says is Improved and Expanded Medicare for All. And I think that's really important, because when people think about Medicare, they think of our current system, which only pays 80% of your bills, and you need copays, and you need deductibles, and you need all these other things. And this is one of the exciting parts of the new plan. So, although Walter Cronkite hasn't been with us for 10 years, he said it, and he said it very well. The American healthcare system is neither healthy, caring, nor a system. That's the truth. All right, so the problems lie in three major areas. We're going to cover all three of these: access, cost, and quality, and they are closely intertwined, as you'll see. As a matter of fact, cost is one of the reasons for the lack of access, and lack of access is one of the reasons for the lack of quality. So you'll see how it's all sort of a giant slow snowstorm or snowball careening towards disaster. We're going to talk about cost first. Now, the United States has tons of money. I want to show you this slide because it shows the top 10 countries of the world's GDP. GDP, gross domestic product, is all the goods and services that a nation produces. And as you can see, the United States on the far left is at a high, followed by China, and there's other countries that come down later. We have just a lot of money. I was going to use some other terms, and I realized this is being recorded. A lot. Okay, but we spend a lot on healthcare. As a matter of fact, we spend way, way too much. I think it's important to notice the healthcare expenditure as a percentage of GDP. So I showed the GDP first. I think that's helpful to get a feel for where we are. Out of that enormous amount of money, we spend over 17% on healthcare, and that's way more than all of the other countries that are listed here, and all of those other countries have national healthcare. So they spend a lot less and they get a lot more, and you'll see more about that as we go on. And then you can break it down in a different way. Instead of GDP, you look at per capita. So for each person in the country, how much do we spend on healthcare? Once again, way, way, way more than we should, and way more than the others do. So as you can see, in the United States, we spend $10,224 per year. Per person. In 1960, the average cost per person was $146. So it's gone up just a little. And then I really like to point to Japan because I'm going to use Japan a lot for comparisons, and there's reasons for that that you'll see as we go through the talk. But they spend roughly half that, $4,700 per person. Now, this shows what you pay for health insurance premiums. And as you can see, it's relentlessly marching up. The the lighter blue line is for individual coverage, and the darker blue is for family coverage, and this is estimated to be a family of 4. These are insurance premiums. This is what you pay to get health insurance per year. And as it marches up, it gets more and more unaffordable. But the problem is, as the premiums march up, so do also the co-pays and deductibles. So you're paying both ends. You're paying more for your premiums. You're paying more out of pocket at the time of service. That's a lot of money. And what are we paying for? So the idea is you buy health insurance to cover health care, right? It's not so much. All right, here we go. So here's the growth in physicians, and as the population has grown, so have physicians, but not terribly dramatically, as you can see. Here is the increase, and guess what that pale blue is? Administrators. That's right, that's what we're paying for. Woot, woot, woot. How many administrators have you been to in the last 3 months? And how did they impact your health care? All right, well, let me tell you, actually. The administrators that work for the healthcare industry, so the Blue Cross Blue Shield, Aetna, et cetera, make the money for the company. And the way they do that is by what? Denying. Exactly, denying care, denying claims, making it very difficult. I first came up against my own personal definition of white privilege when I got so outraged about one of my patients who had calmly and patiently and, in my opinion, stupidly accepted a denial from their health care insurance. I said, you didn't, protest, you didn't call, you didn't write a letter, you didn't. No, I got a denial, And I realized that there's a lot of people for whom no means no. They don't understand the system. They don't understand the system. And you have to fight the no, but why should we? It's pretty egregious. Moving on. Oh, let me go back to that for just a second. Well, you can remember what the slide looked like. Who are these administrators? Do they just work for the health insurance companies? No, they actually work for a lot of people, but they work for doctors in hospitals as well. The folks in my office as physician worked trying to deal with health insurance. So we had tons of people that all they did was try to get pre-certification, try to get denials overturned, try to get things covered, and hospitals have the same thing. And the insurance companies have the counterparts trying to say no, and that's kind of nonsense. All right. So in the United States, we spend $3,006 per year per person on administrative costs. In Canada, that figure is $787 per year. Well, here we go. CEO salaries. This is money taken out of the healthcare system. This is money that does not benefit patients. It does not benefit hospitals. It does not go to fund research. It does not go to fund people who are medically uninsured. It does not go to fund anything but their second yacht. If I seem a little hostile, I apologize. All right, so the U.S. pharma company CEOs are no pikers when it comes to taking a paycheck either. And I do want you to look at these numbers and also realize at the very bottom it shows that the average salary for a full-time wage earner in the United States is $43,264 per year. So I think they're making out pretty well, and I don't have a whole lot of sympathy. In fact, this industry is so profitable, I think it's obscene. Of publicly traded companies, of 85 healthcare companies, their profit was $47 billion on $250 billion in revenues, which is an extremely healthy profit margin of 18.8%. Any of you who have your own business, can you raise your hand if you have your own business? Okay, who makes 18.8% margin? Who? Stand up. Come on now. Come on. The average grocery store has a 1% margin, just to give you an idea of how outrageous this 18.8% margin really is. And it's driven, this profit is driven by prescription drug sales, medical devices, tests, and procedures. You can call that healthcare if you want to. I would say to you there's lots of room to improve in what is really healthcare and really what we spend our dollars on. So also in 2017, if they weren't healthy enough and if they weren't making enough money, our current, well, our 2017 legislature passed a hefty tax decrease, so now they're even more profitable than they were. So that's our tax dollars at work, or lack of tax dollars to do other things. So let's take a look. Where have the profits been? Pharmaceutical, woohoo, $67.7 billion in the year 2016. Insurance company profits, $15.1 billion. Medical equipment and devices, wow, they're raking it in at $10.4 billion. I love the next category, pharmacy and laboratory manager profits. Who are these people? Most people have never heard of them. I see my sister has a puzzled look on her face, as well she should. These are people who negotiate with big companies what drugs will go on their formulary, and they take a piece of the pie. Thank you very much. And who else do we have? Oh, medical distributors and wholesalers. Those are folks that add a lot of value to the system. And finally, at the very bottom, we've got providers who do make $2 billion. Providers include for-profit hospitals, of which there are practically none that are non-for-profit anymore. And it also includes clinics and so on that are for-profit, some of whom are owned by physicians, some of whom are not. All right, so we've talked a little bit about the cost. I hope your blood is boiling, as it should be. Now it's, and if not, I'm going to come take your pulse or clean out your ears. All right, so next it's access, and this is, in fact, critically important. This is really the crux of the bad news. All right, so uninsured. This is a really interesting slide when you look at it, because at the before World War I in 1940, virtually everyone was uninsured. Health insurance didn't exist. People paid their doctors. They would negotiate a price if necessary. Some paid in kind with chickens and eggs, I've been told. I don't know. I wasn't around at that time, but nobody was insured. And then after World War II, employers started to feel a lack in the workforce. They needed something to get more workers, and one of the things that was decided upon by a variety of people, but this actually started with Blue Cross and Blue Shield in Texas, believe it or not, great state of Texas, where the employer decided it would be a good thing to have healthy workers because they would show up for work. And the workers said, you know, I have car insurance or house insurance and maybe life insurance, who knows. Insurance makes sense because then if something drastic happens, I'm covered, and none of us ever know if something may occur. So injury or illness can occur to any of us. So thus started the employer-based insurance system that is with us to this day. And at first it was non-for-profit and had, I would say, good motives. It has changed, as you can tell, quite a bit. The first president to really strongly advocate for a national health plan was Harry Truman. And he did it right after World War II. That's when Great Britain installed their national health care system. And as you know, Great Britain was devastated by World War II and didn't have a whole lot of money, but they made money for something they thought was important. The United States did not. Eisenhower, thank you, also proposed national health insurance. and didn't really get that through. It wasn't until Lyndon Johnson in 1964 that Medicare and Medicaid came to be. And at that time, the number of uninsured dropped rapidly. As you can see, there's a big dip in that slide. So Medicare was designed to help people who were over age 65 and presumed to be retired and no longer eligible for employer-based insurance. Medicaid was designed for those who are poor and either don't work or can't afford health insurance. So that's what those two programs were designed to do. Medicare was expanded later to cover disabled folks. So it is also expanded to cover children even. So they've evolved a bit through the years, but as you can see, a large number of people got insurance. And then the number of uninsured started to climb again for a lot of reasons, mostly cost. Then the Affordable Health Care Act, ACA, known widely as Obamacare, came in, and the number of uninsured dropped again. But why is it climbing? Anybody want to venture a guess on that one? You guys did so well on the other question. Okay, beg your pardon? What did you say? Trump and other Republican legislator has been chipping away at Obamacare, and in particular, they took out the provision that said this is mandatory or you'll pay a fine. So with that provision out, guess what? People that thought they were healthy and wanted to roll the dice and hope they didn't get sick, dropped it. So it's estimated that if things don't change, the number of uninsured is going to continue to climb, and 50 million Americans could be uninsured by the year 2026. All right. Locally, it's important to know that we have not escaped this. In Kansas, we are uninsured at the rate of 8.4%. In Missouri, an embarrassing 9.8% of our population, or 640,000 people, are uninsured. Uninsured means nothing. They've got no Medicare, no Medicaid, no private insurance, no Obamacare, nothing. All right, they're bare. And even Medicaid, which is extremely stringent in Missouri, is shrinking. And it's shrinking in ways that are inexplicable. Last year, 77,000 Missourians were dropped from Medicaid with no explanation. And of that 77,000, 50,000 were children. If you're not upset, well, I'll be upset for you. Okay. So this is an interesting map because the darkest blue are the highest number of uninsured, then the medium blue is sort of a medium, and the lightest blue is the lowest number of uninsured. And it sort of goes along with philosophical differences in these places, although it is interesting to note that California has a pretty high number of uninsured. All right, so it's important to understand something besides uninsured. So uninsured, everybody knows what that is. We just talked about it. Underinsured is a very important concept, and the number of folks who are underinsured, which probably includes almost everyone in this room, is the state of an individual having some form of health insurance, but it does not cover complete financial, it does not offer complete financial protection. An underinsured individual lacks the ability to cover their out-of-pocket healthcare expenses. So let's dig down just a little bit deeper. The number of underinsured is also climbing. And the reason for that, most of you who have health insurance through your employer or some other way know, is increasing out-of-pocket expenses. Deductibles, co-pays, co-insurance. Those are three words that I can talk to you later about. They're curse words in my view. My last year of employment in 2018 as a physician, working for a big company, HCA, Healthcare Company or Hospital Corporation of America, a healthcare company, okay? You'd think they would care about my insurance. I had an $8,000 deductible, okay? Now, as a physician, I could pay that, but it often would give you pause. It often would, do I really need a mammogram every year? All right. So high deductibles It compromises finances and it compromises access. I think this slide is fascinating. The light colored bar is high deductible. The medium blue bar is low deductible. But notice two things. There are people having problems paying their medical bills in both plans. And there are people who defer or delay care in both plans. And as a physician, and those of you in this audience who are healthcare professionals, and I see quite a few, you know that delaying or avoiding healthcare doesn't lower your cost, okay? It increases the cost in two ways, the cost to your health and your costs eventually. I remember there used to be this car ad for, changing your oil or something, and the guy said, you can pay me now or you can pay me later with a complete engine overhaul. And that's what people are doing. They're sort of gambling with their health because they don't want to pay all that money, or they can't. All right, so what are the consequences of being underinsured besides bad health care, besides delaying and avoiding care? Here it is. Off-ramp to bankruptcy. This study is very recent. It was published in 2019. 87% of personal bankruptcies are due to medical expenses in the United States. And of that group of medical bankruptcies, 78% of the people had health insurance when they got sick. So, does health insurance save you? Does it save you money? Does it pay for your needs when you get sick? I don't think so. Medical impoverishment, which is common in poor countries, is almost unheard of in wealthy nations outside the United States. This is a national shame. Private health insurance is a defective product, akin to an umbrella that melts in the rain. All right, quality. Is it any wonder that our quality is totally crap? I used to hear this from people. Oh, the United States has the best health care in the world. Pardon me. I hope that didn't blast out the, at any rate, that is inaccurate to say the least. Let's take a look. All right, first of all, life expectancy, woohoo! We're number 25. We're number 25. Yeah, okay. So our life expectancy is number 25, all right? I don't consider that the best in the world. Average lifespan for a man is 75.2 years, and for a woman it's 80.4 years, which is only the 27th in the world. So even us women, strong as we are, can't make it in this system. But what about specifics? Maternal mortality is, it's a tragedy. Okay, so more women die in childbirth in the United States by a large margin. We are that first bar on the left. Take a look at that. And the babies die too. Infant mortality is not only higher, it's on the rise, and so is maternal mortality. What did I say about delaying or avoiding care? Are there consequences? There are. And the most vulnerable of us are the most vulnerable to those consequences. So the percent probability of dying due to cardiovascular disease, cancer, diabetes, or chronic respiratory disease in 2016, hey, we are number one. Your chances are higher of dying from these problems, treatable problems. And I want to point out that most of those problems have been linked to smoking. And although ours is more than almost twice what Japan's is, there are more Japanese who smoke. So it's not just bad habits. We've got them, not going to deny it, but it's not just bad habits. It's bad health care. All right, so the percent of population receiving long-term care, think nursing home, a dismal 0.4% of people in the United States receive nursing home care. Now, none of us want to go to a nursing home, but there are quite a few of us who need it, but we don't get it. It is not covered by traditional health care. It is not covered by Medicare. And it's only covered by Medicaid if you spend all of your assets and impoverish yourself and have absolutely nothing. And even then, if you have Medicaid, you got to find what's called a Medicaid bed, which sounds odd. What's a Medicaid bed? Does it have special mattress? It's really comfortable? No, it's a quota. There's a quota of beds that are available for Medicaid payment, and it's very low, and of course, they're often not available. Or if they are, they're not available in your community. Now this one, this is why Japan, I love Japan. Oh my God. Anyway, you'll see. Number of visits to the physician per year. We are the lowest at 4 visits per year. Look at Japan. Oh my gosh. 11 visits per year? I can't read it. 13, thank you. I knew it was more than 1 a month. Thanks, David. That's a lot. That's a lot. Now, remember this. If you think to yourself, oh, I don't go see my doctor 4 times a year, this includes your eye doctor, all kinds of doctor visits, okay? But here's the thing. Japan spends less than half of what we do per capita. How can they go see the doctor that often? How does that work? Where they get to go to the doctor, they get better outcomes, and they pay less than half. How does that work? All right. Well, we'll touch on that when we come to solutions. So keep that question in mind. But there are years of life that are lost due to premature death. And premature death means if you have been treated often and early enough, you need not have died as early from your condition. Now, this may be a newsflash for some of you. Probably most of you are aware we're all going to die. Excellent. Some of my patients didn't seem to really grasp that, so thought I'd bring it up. That's not necessarily the bad news. The bad news is you don't want to get disabled. You don't want to suffer. I mean, that's what people fear. They really don't fear death. They fear suffering and disability. And we've got it untold, and it's unnecessary. All right. So watch the news. We got great stuff coming, like the CDC data show that U.S. life expectancy continues to decline. Now, a lot of the driver for that is suicide and drug overdoses. And if you don't hear me say anything else today, it is that mental health and substance abuse is woefully underfunded in this country, and it is a tragedy. We are paying the price in people's lives. Sorry. Okay. The U.S. ranks as the only developed nation with increasing maternal mortality, and I should mention infant mortality. What does that one say? America's ranking on amenable mortality is an embarrassment, and it is. Amenable mortality means we could have done something. We could have helped. Medical errors are a big cause, and we can talk about how our system actually does not address that. And this one says your odds of dying from accidental opioid overdose in the United States surpass those of dying in a car accident. Okay, and then finally this little one says for-profit hospitals are related to a higher readmission rate. What does that mean? It means they're for-profit hospitals and they're sending you home too soon and too sick. Thank you. So, as we all know, time to fix the roof is before it rains, but it has been raining for a long time. What happens when you turn 65? Not like the Beatles song 64. The wonderful thing that happens then is you become eligible for Medicare. And Medicare is a good program, and it works. And if I don't have the slide for it, but I do have the statistics that show that our life expectancy and our outcomes are very much better once you make it to 65. If you can hang on, hang on tight and make it. You may survive. All right. Now, I'm going to make some definitions, and I think these are really, really important, and people get very confused. Universal health care means access for all. Okay, all. Good. Socialized medicine, which is a bugaboo that people will try to scare you with this, means that it's publicly financed and publicly owned. In the United States, we have that in the VA system. In Great Britain, that's their entire National Health Service system. But the single payer system, which is the proposal in the bills that I'm going to tell you about in a sec, is what is proposed here in the United States. We already have it in Medicare. That means we have a single payer, but we have multiple privately owned delivery service. So you don't go to a doctor that works for the government. Your insurance is covered by the government. The government pays your doctor, but they are not employed by the doctor, et cetera, et cetera. Okay, I hope that makes sense. That confusion really gets people. This is the most important slide today. I want everyone to listen carefully. Progress is impossible without change. And those who cannot change their minds cannot change anything. All right, so what is it? What are we proposing here? What's the good news? Woohoo, I'm finally getting to that. Lots of bad news first. We are proposing, when I say we, I mean many, many people in the U.S. legislature and in various groups. The group I belong to, Physicians for a National Health Plan, believes in the single payer. So we eliminate the financial barriers, no deductibles, no copays, no coinsurance. We eliminate the wasteful overhead, and I'll show you just how much savings that comes from that in a sec. We can have predictable costs, and this is huge for business. Businesses that give health insurance to their employees know that their costs are going up, but they don't know by how much year over year. They just know they're going to go up, and that, according to Warren Buffett, is the largest thing that stands in the way of U.S. businesses being competitive overseas to these other countries, because these other countries have health insurance. That's not on the table for the employer. Also, it fixes a lot of benefit gaps. We're going to expand traditional Medicare, include every American, including Congress, and I like that part because whatever they vote on applies to them and their families as well. And it's expected to include comprehensive care. The next slide will show more about that. And very importantly, negotiate costs. So in addition to negotiating costs for medical devices and drug prices, there's also negotiated costs for hospitals. There is going to be a global budget for hospitals that they use on patient care. There'll be a separate budget for capital expenditures, like if they want to buy a new MRI or something like that. And that forces hospitals to provide care that is effective and care that is cost effective as well, because they're on the hook. If they send you home early, it's just going to cost them more in the long run. All right, so there's two bills, and the Senate bill was just recently reintroduced by Senator Bernie Sanders this last week, and the bill in the House is now called House Bill 1384. Take out your cell phones if you're interested on that address, but you can just go to usgovernment.com and find, usgovernment.gov, and find that information. So what is in it? Let's just do a little summary of House Bill 1384. Comprehensive benefits. 98% of U.S. physicians and providers, that means hospitals and clinics, are in the network. There are no premiums, no deductibles, no copays, no out-of-pocket costs. So I should mention, no bankruptcy. It covers long-term care, both in-home and in a facility, and that's extremely important. Medicare currently covers some of that, but you have to have certain conditions, and it's very limited. If you go to a rehab facility, you can have 100 days on Medicare, but you have to show improvement day over day, and you have to be certified to have the kind of condition for which that is paid for. It also, the costs include your medication and your Medicare medical devices, and that includes anything from a heart valve to a wheelchair. The transition to a single payer would occur over 2 years, and it's called a just transition. I think this is important, and I'll tell you what that means. It means that for the first year after this passes, the folks who will lose their jobs, and I'll show you the numbers in a sec, the people who currently work for health insurance industries or who work for doctors or hospitals fighting the health insurance industries will most likely lose their jobs. Their jobs will become redundant. So it's going to provide a full salary for the first year and job retraining. So folks can go into other insurance industries like life insurance or car insurance, or they can go into something else. Maybe they could even go into healthcare. Who knows? We will need more providers. The VA and the Indian Health Service are carved out. This is the real reason to celebrate. So if anybody feels like putting up their hands, what's going to be covered? Yes. Hospital care, emergency care, primary care, prevention and wellness, mental health, hello, hallelujah. Yes, and what? Substance abuse treatment. I'm thinking. All right, rehab services, reproductive services, and that's kind of important. I hate to say it, but if you work for a Catholic hospital, you don't get your birth control paid for, and it's expensive. So now everybody gets reproductive services. Vision and hearing care, and I want to mention that includes glasses and hearing aids. Dental services, can you believe it? Not cosmetic, sorry guys, probably not, but your basics, which is very important for your health, medical equipment, and prescription drugs. All right, so Medicare for all, single payer means improved access. It means this is for everyone, all the time, regardless of employment, and it's for all services. Vision, hearing, long-term care, mental health, to a network of providers that includes 98% of the current providers with doctors and facilities throughout the United States. So if you have Missouri Medicaid, you can get care in Oregon. Medicare for all means providing health care. Now, those that really may not get this, but it's okay. This is a huge paradigm shift. And it's so exciting for those of us, and for me, who's been in primary care for so long, because it's going to be a shift from profit motive and the culture of disease management to a single payer system. It's driven by keeping you healthy, and it's not based on your ability to pay. Wow, that actually sounds like healthcare. It's the first thing I've heard today. It sounded like it. All right, so where are the cost savings coming from? Overhead, take a look. These are some of the health insurances and their overheads. They're in red. Look at that little teeny tiny 2.2% of Medicare. That's their overhead costs. There are approximately 4,000, or make that 6,100 Medicare employees. Commercial insurance employs 470,000 people. So those are the folks that probably will be losing their jobs, including the fat cat CEOs, but they'll get retrained. And as you may not know, but currently the unemployment rate in the United States is at a very low rate. So there's jobs out there. It adds up to $500 billion a year in savings. And that's just overhead. Okay, Medicare for all makes economic sense. There are new costs. What are they? Medicaid rate adjustment needs to go up. The current reimbursement to providers from Medicaid does not even cover the cost of providing care. Sadly, when I was in practice, we could not accept Medicaid as primary payment because we were not a safety net provider. And what did that mean? That meant if we saw Medicaid patients, it cost us more to provide their care than we got in reimbursement. Just kind of a non-insurance, if you ask me. Oh, okay, so I'm going to have to buzz through. We're going to cover the uninsured. That's going to add some cost, but that's a good thing. We're going to increase utilization because we're covering more things, home health, dental, and so forth. But there's savings. The savings are on administration, health insurance administration, and administrative costs to providers. We talked about all those people sitting in doctors' offices fighting with insurance companies. So the savings actually outweigh the new things, but look at this one, negotiated prices for drugs and devices. Woo! And some of those savings come out of your pocket. Medicare would work. How do we know? Yeah, it's going to require some taxes. We estimate that employers will pay, this is actually in the bill, the House bill, 6.2% of their employees' compensation, and the employees themselves will pay 2.2%. That adds up to 8.4%. But you're not going to have to pay all that extra. The premium, the co-pays, the deductibles, and the premiums that are currently coming out of your check, you're going to save money. So that currently is 20% of the salary. It's going to drop to 8.4% under this plan. So workers who get their insurance through an employer are going to save tons of money. 99% of us come out ahead. There are 27 independent studies that show that this will work and that it will save money. Under Medicare for All, spending would drop to 15.8% of the GDP almost immediately, and over 10 years, $5 trillion in savings. Here's such an important thing, improved health outcomes. So we'll have healthier people, and that in turn will improve productivity. It will support greater income inequality. It will support job creation because small businesses can afford to hire people. And there's a just transition to support those folks who are going to lose their job. This is nonpartisan. This is not Democratic or Republican. However, when asked, do you support or oppose a policy for Medicare for All, 85% of Democrats said yes, and 52% of Republicans said yes. When asked, is it the responsibility of the federal government to ensure that all Americans have health care and coverage, that yes percentage has gone up sequentially, and it's even higher than that now. That last data was 2017, in which 60% of people said yes. And even us fat cat doctors, yes, 56% and counting, that's going up as well, are in favor of Medicare for All. So the legislative support has grown as well. In 2004, when the first bill was introduced, it was called House Bill 676. There were 38 co-sponsors. By 2017, there were 122 co-sponsors. This new bill is new and only has 107 co-sponsors. Please call your representative. And Frank, how wonderful it is that nobody need wait a single moment before starting to improve the world. So, if you're riled up, and I hope you are, you might want to know what's next for you. First and foremost, be a partner in your own health care. Know what your conditions are, know how they're being treated, know what your medicines are, know what tests and x-rays and so on are being ordered and what the results are and how they will change the outcome of your care. Be informed. Promote the health of your community. Need I say it? Get your vaccines, people. All right, get informed and learn about this issue. The more you know, the better an advocate you can be. Promote healthcare conversations in your community, in your families, in your friends. Contact your representatives to support single payer. Join a healthcare advocacy group like Healthcare Now or Physicians for a National Health Program. Get out your cell phones. These are some reading assignments for those of you that are interested. Here's some websites for health policy. Thank you very much for giving me this opportunity. I really appreciate it.
Is that not great? Would the ushers come forward and take up the collection for the church? And let me remind you, we're going to have questions and not statements. If you'd like to make a statement at some point, you can come to the library afterwards where they're going to be generous with their time and make your statement there.
Okay. This question is for Beth. I want to go back to your discussion of the patient you had who was denied and did not appeal. Okay? fairly recently, I was denied one of my medications. I was sent a letter, and in very clear terms, they told me what I needed to do to appeal, which I did. And in like less than a couple of weeks, I actually got approved for the medicine. So my question to you is, what are the psychological or any other impediments to people making a successful appeal? Why are people not appealing, or if they are, how often are they getting denied? Can you talk about that?
I'd almost like to give this one to David Terry, but I did become an expert in domestic violence and battered women, and one of the pivotal studies is a study by a guy named Seligson called Learned Helplessness. Learned helplessness was a study in which dogs were put in cages and given random shocks regardless of their behavior. And those cages were closed, but later on, the cages were opened and the dogs could have walked out, but they didn't. They just expected bad outcomes. It's called learned helplessness.
Thank you very much for the presentation. It's very informative. I also appealed something and it was continued to be denied, so I just refused to pay. I have a question concerning the healthcare and provider deserts that we have in our country, especially in the rural areas. How will this legislation address those areas? Because they're rampant and it's a huge problem. Thank you.
I love that question. So the question is, how do we support those rural communities that don't have health support now? One of the issues is when you have an insurance program, that insurance company is now making contracts with hospitals and physicians throughout different communities. Well, if you're in a rural area, it's not a benefit for an insurance company to support those people. So the people that have the insurance will then go to the KUs and to the St. Luke's, and they'll leave their communities for care. And so we get into this competitive nature, this competitive scenario. With Medicare for All, what happens is that small communities that have hospitals, that have physician providers, and that really want to support their community will get a budget. And all hospitals, all physicians will get paid the same amount. There won't be any That's right. So now what happens now in our situation is that the hospitals that don't have those contracts, they're caring for the poorest of the poor that can't pay or that have Medicare, and they can't keep their doors open under that. So under Medicare for All, what happens is that a hospital will get a budget for the number of people that they're cared for. So it provides a community support to provide health care. In eastern Missouri, northeastern Missouri, there are no hospitals. People cannot afford to see a doctor. There's nobody there. And that is the capitalistic venture, the competitive venture. It ruins communities. If you think you have a hospital, then you have a school. And from a school and a hospital, you have industry. And so all of these things really need to support part of our infrastructure. That's a great question. Thank you.
Excellent presentation. Thank you. I want to focus on of the three elements you talked about, quality of our healthcare system. It looked certainly that the quality is affected by lack of insurance coverage, and also by inadequacies in the healthcare system itself. You talked about medical errors and so forth. And in looking at negative outcomes, I felt those two components were lumped together. Do you have any data that disentangles the two? To what extent do the negative health outcomes can be attributed to lack of proper coverage versus poor quality of the actual healthcare system itself?
Thank you. That's another great question, because it really goes to the basis of what is healthcare. Health insurance is not healthcare. Medicare for All changes the scenario in that you are being provided healthcare by the government. The way the government makes money under Medicare for All is that you save it by keeping people healthy. So it's really not insurance. It is providing care. health insurance, when they broke it down, health insurance versus no health insurance, they found that people suffer because they didn't have health insurance. For people that had health insurance, the quality measures increased. But when we don't have so many people, almost a third of our population, which are underinsured, those people are going to suffer from lack of any type of proper health care, because they don't go to the hospital. They take the strategy of, I can't afford health insurance, so I'm going to buy policies which don't provide me with health care. And they suffer from it when they go to emergency rooms. This is where I like the thought of taking out a dollar bill and tearing it. Because if you like the system we have now, this is what your dollar is worth. It's not worth 100 cents. It's worth 66 cents.
Hi. This is for taller people, I guess. Hi, I'm not from the state of Missouri. I'm visiting a friend here, but I know that Missouri is one of the states who has not expanded Medicare under the Affordable Care, or Medicaid, sorry, for the Affordable Care Act, because your elected officials have decided not to do that. Is there a movement to encourage them to approve this expansion? Well, no, it's a state, state decision.
Right. So yes, it's going to require a change in the power, the party in power. Okay, our current party in power does not want to do it, and so it has been loudly and repeatedly turned down. Our current party in power has thrown people off Medicaid for no reason. Our current party in power has set up rules that you get actually zero in income before you get Medicaid, but you have to work in order to get Medicaid. And if you work, guess what? You no longer qualify for Medicaid. Woohoo! So I could go on and on about Missouri legislature and some of the things that I've tried to impact. But this needs to be a national solution, and a piecemeal solution like expanding Medicaid is inadequate, to say the least. And that's where I'm going to leave it.
I have a question about the availability of healthcare professionals, particularly in primary care. As you know, an average medical student leaves with a debt of about $300,000. But in addition to medical students, which we've had a lot of talk about, you now have to get a doctorate in physical therapy or occupational therapy before you can practice, which means 5 years in school at around $22,000 a year. So do you think we have to do something about that?
Absolutely. And at the risk of being a microphone hog, and I apologize to my colleagues, the ACA had provisions for medical education, and that included not just physicians, but nurses and therapists and so on. That was never funded and has never kicked in. So, yeah, that needs to happen. And I think, what's the right word? I think that the capacity of the medical and nursing schools and therapy schools is such that as demand increases, that could rapidly be accommodated. Addressing the debt, student debt, is huge and important, and yeah, should be part of this. It's not part of the House Bill 1348 because it's going to be hard enough to get this through. So they focused on eliminating for-profit health care in the United States in favor of a national plan.
I think what your question in some way has been related to maybe you've seen the 60 Minutes last week. Yeah, but there was for those who didn't have a chance to see it. I think New York State University provided tuition-free medical school first in the country. NYU, right. NYU. So obviously this is the huge issue for a lot of starting medical professionals, for both in medical schools, in pharmacy school, nursing schools, a huge debt. And that is directly related to types of the services that are being provided down the line, because obviously if you end up leaving school with $200,000 debt, you're looking for more profitable parts of the medical care. So less likely that you're going to be a general practitioner working in, outside of Wichita. That's less likely. So maybe you can go to dermatology or some other more specialized areas. But this is the one of the problems with which we are dealing in general, and that is that everything is ruled by money. The system, our healthcare system is really based on the profits. And if you look in the global situation, most of the civilized countries, so to speak, they do have a very, very different setup as far as a payment for the healthcare, and so it's not related to or not emphasized on the making profit per se, but for preventive medicine. And I think we'll talk a little bit or touch on the prevention here, or maybe we did not, but this is the part which we do really badly lacking here.
That was the point of my question.
Yeah, right.
Good question.
Great. Thank you very much. Your presentation is very well done, and the information you present is very representative of what I understand to be the problem and some of the solutions. But I have two concerns. One, there's going to be a lot more people going to see doctors and medical professionals. Are we ready? And how do we get ready? And part of it is the questions about education. And in some ways, I think some of the statistics about the jobs being lost may be overstated, because with more people seeking medical attention, yes, the administration part needs to stay 2.2% or somewhere much less than what it is now on the administration level, but the program's growing. So that doesn't mean all those jobs will be gone. The number of health professionals is going to grow too. So I'm not sure it's as big of a job loss deal as maybe has been stated. And that's not a bad thing. The good thing is, the question is, are we ready for the onslaught? And two, doesn't Medicaid go away?
Yes.
So I'd love to answer this because it follows your question as well. We have the same number of doctors per capita as many other countries, yet we're able to don't provide care like other countries do. There will be a shift, and not only is it going to be between administrators and people who are getting those services, but it's also within the doctor's office. Because they spend a lot of time, and I know this, I spend a lot of time doing charts, calling insurance companies, talking to people, and it wasn't involved in care. So when we look at taking that component away, we're actually increasing the amount of time that each doctor has to see somebody else. So I believe we are ready. We are going to come up to some speed bumps. Completely agree that there will be speed bumps in being able to implement this. But that's part of the growth. That is part of the growth.
And make it a quick question.
If we have people that are healthy, it's gonna propagate itself to all corners of our lives.
Quick question.
Yeah, we talk about the physicians, and I have great respect for the physicians, but let's face it, more of our nurses, our techs, all of our emergency care things see more of the patients than even the physicians do. How are we going to encourage people to go into those fields when we keep seeing, and our young people keep seeing, the abuse that they take in their jobs and the quality of life that they have? We also have to come up with that. And my concern is, how does this bill address getting that taken care of too, providing the training? I mean, we're losing our nurses and our other stuff.
We got it. The question needs to be stopped.
We're going to go.
Thank you.
Thank you.
So the question that you have is how to encourage people to get into healthcare, and the answer is, thank you. The answer is, and I appreciate it, but the time is gone.
We're running out of time.
So the answer is, the reason people are so stressed out in emergency rooms is because they're damn scared. They don't know how they're going to pay for it. They don't know what's wrong with their health. They don't know where they're going to go once they get that acute care in the emergency room. When we have a system that covers people and takes care of their needs, it is a better system to work in. It is going to be well paid. We don't estimate that anybody is going to see a decrease in salary other than those that actually lose their jobs at insurance companies. So it's going to be better to practice. It'll be better on this side of the bed. It'll be better when you're in the bed. And I think that's the answer to your question. Thank you so much.
Yeah.
Sorry to have to cut you off.
Come to the library afterwards and you can ask a question or talk about it. Let me first off give the honorariums to these speakers. We give these wonderful blue coffee cups made in the U.S., union made, and they're a treasure for your home.
Yes, thank you so much.
Next week we have somebody speaking on the Green New Deal, Winston Apple. We'll be here, and you're more than welcome to stay for the service today. And thank you for coming to the forum.